Hi everyone, this is Nafis, and welcome to another episode of Medical Mayhem. Today's episode is called TramaDON'T, so let's get right into it. A 26-year-old woman presents with a one-day history of altered mental status, with diarrhea, vomiting, and excessive sweating. Her partner tells you that she's been very confused and not acting like her normal self. He also tells you that yesterday she had gone to her family doctor and was prescribed Tramadol for her chronic pain. Her past medical history is significant for fibromyalgia and depression, for which she's been taking Prozac for many years. She doesn't use alcohol or any other recreational drugs. On exam, she appears unwell. She's hyperthermic with a temperature of 40 degrees Celsius, tachycardic with a heart rate of 140 beats per minute, tachypnic with a respiratory rate of 26 breaths per minute, and hypertensive with a blood pressure of 150/87. She's satting 91% on room air. She's visibly agitated and has a noticeable tremor. She's not oriented to time or place. Her pupils are dilated at 9 millimeters bilaterally, and equal and reactive to light. She has very brisk reflexes in the lower extremities. There was clonus at the ankle, and you notice twitching of her eyes several times. She starts shouting and doesn't fully cooperate. You discontinue the exam as she tries to violently attack you. I'll start off by saying this was caused by drugs. The real question is, which drugs were behind this? Let's talk about some of the major toxidromes that can present this way. The first, which I think is the easiest to understand, is the Sympathomimetic toxidrome. That's when you overdose on something like cocaine or meth, which activates the sympathetic nervous system, or SNS, which is part of your fight or flight response. If you were walking in the woods and you saw a bear coming towards you, hold on, let's get a scarier bear, and you start panicking as your fight or flight response is activated, what kinds of things do you think would happen to you after hundreds of thousands of years of evolution? Well, for one, your heart rate goes up, your blood pressure spikes, you breathe faster, and you start sweating profusely. All that activity in your body makes your temperature go up. Another thing that happens is your pupils dilate to let more light in, and you can see your surroundings better. The opposite of the sympathetic nervous system is the parasympathetic nervous system, or PNS, and it coordinates the exact opposite of the fight or flight response, the rest and digest response. It's what takes over when you're chilling, just sitting on the couch watching Netflix, decreasing your heart rate, respiratory rate, temperature, blood pressure, and perspiration. These two responses keep each other in check. In normal times, they balance each other out. The major chemical the PNS uses to do its job is acetylcholine. So if you block acetylcholine, the parasympathetic nervous system shuts down, and the sympathetic nervous system steals the show. So in the anticholinergic toxidrome, where acetylcholine is blocked, you get most of the same things: increased heart rate, blood pressure, temperature, and pupil dilation. One thing that is different is urinary retention. There's an even bigger distinction, though: the decreased sweating. Acetylcholine isn't very loyal. It mostly helps the PNS get stuff done, but it sneaks behind its back from time to time and helps the SNS out with one thing: sweating. So when you take acetylcholine out of the equation, you become dry instead of sweaty, unlike the sympathomimetic toxidrome. That's also why you get really hot, because you need to sweat to get rid of all the body heat. Recall that our patient is very sweaty, so it's not an anticholinergic problem. The other two toxidromes relate mostly to psychiatric medications. One is neuroleptic malignant syndrome, or NMS, and the other is serotonin syndrome. NMS is caused by antipsychotics, while serotonin syndrome is mostly caused by antidepressants that increase, you guessed it, serotonin. In both of these, you get all the same things with the fight or flight response I already talked about: fever, tachycardia, diaphoresis, pupil dilation, and elevated blood pressure. They both cause diarrhea and vomiting as well. So even though we know that our patient has all these things, it doesn't help us at all with distinguishing the three toxidromes we still have on the table. Where they start to part ways, however, is with neuromuscular hyperreactivity versus sluggishness. NMS is sluggish. You get muscle rigidity, where you're very stiff, and you get bradyreflexia, which means weak reflexes. Think about NMS as restraining your muscles, holding them back. In serotonin syndrome, you get hyperreactivity of the muscles, including hyperreflexia, meaning brisk reflexes, as well as tremors and myoclonus, which is involuntary jerking of a muscle group. I recommend looking up a video to see what myoclonus actually looks like at the ankle. So think of serotonin syndrome as letting your muscles run loose and get out of control. So between the sympathomimetic toxidrome, serotonin syndrome, and NMS, which sounds the most likely? Let's go back to her history and physical. She's got the things that are common to all four of the toxidromes I talked about: tachycardia, diaphoresis, hypertension, fever, and pupil dilation. None of that really helps. But notice how she has a tremor and also hyperreflexia in her lower extremities, and there's nothing about rigidity there. She has clonus at the ankle, And the twitching of her eye is actually something called ocular clonus. It sure does sound like she has the neuromuscular hyperreactivity that we get in, remember? Serotonin Syndrome. She also apparently doesn't take any recreational drugs like cocaine or methamphetamine that would cause a sympathomimetic toxidrome, but in real life I wouldn't really believe that, and order a urine toxicology screen anyway. But this is very likely to be serotonin syndrome. So what caused it? She takes Prozac for her depression, which is a selective serotonin reuptake inhibitor, or SSRI. Obviously, SSRIs increase serotonin activity, but she's been taking it for so long. Why is it only causing problems now? Look at this piece of information. She just started taking Tramadol for her chronic pain. Tramadol is a very controversial drug. It gained a lot of popularity in light of the recent opioid epidemic that made providers more hesitant to prescribe your typical opioids like Percocets and Dilaudid for pain control, so they had to start looking for alternatives. Tramadol is one drug that caught their eye. Tramadol is a drug that works the same way as opioids do by stimulating the mu-opioid receptor to reduce pain. However, it binds much more weakly than your conventional opioids. That made it very attractive as a choice of drug that could provide the pain relief of opioids while avoiding the addictive effects. Also, I should clarify that it's not Tramadol itself that binds to the opioid receptor. It actually needs to be converted in the liver to the M1 metabolite, which can then attach to the mu-opioid receptor and provide pain relief. I'll explain why this is important in a second. The thought was that since Tramadol is only a weak opioid, you don't run into the same issue of dependence. The result was that as opioid prescribing started to go down, Tramadol prescribing started to go up, because it's some sort of silver bullet where you get the pain relief of opioids without the issue of abuse. Sounds great, right? But here's why Tramadol is actually a dirty drug. Remember what I said earlier. Tramadol itself doesn't help with pain. It needs to be metabolized in the liver first, where it's converted to the M1 metabolite, which binds to the opioid receptor. The enzyme that carries out this conversion is called CYP2D6. The problem with this enzyme is it comes in many different shapes and stripes, meaning that it can work very differently from one individual and one ethnic group to the next. The word for that is polymorphic. In some people, CYP2D6 may work very well, so they'll get a lot of M1 and plenty of pain relief. But in others, it may barely work at all, so it produces less M1 and they get next to no pain relief. So because of metabolic differences with either a bad or good CYP2D6, Tramadol either doesn't work at all or works way too well in a big chunk of people. There's another problem with this variable metabolism. The actual Tramadol, not the M1 but the precursor, acts like an antidepressant class of drugs called selective norepinephrine reuptake inhibitors that increases serotonin. When you take Tramadol but CYP2D6 is a slacker and not converting it to the M1, you get a buildup of the precursor. All that excess Tramadol boosts serotonin, and when you combine it with an antidepressant that also increases serotonin activity, you run into really big problems. Recall that she takes Prozac, which is an SSRI. When the two serotonin-increasing drugs work together, you get a serotonin storm. That explosion in serotonin activity causes Serotonin Syndrome. So we know that our patient belongs to the lazy CYP2D6 group. There's another thing I want to say. The assumption that allowed Tramadol to gain so much traction, which is that it's a weak opioid and therefore has a lower risk of addiction, is very flawed. In some Middle Eastern countries, for example, there's a higher prevalence of the CYP2D6 ultra-metabolizer phenotype, meaning that their CYP2D6 works way too well. These people get way more out of a Tramadol dose than the average person, and therefore are more likely to fall into a pattern of abuse. So we know that she has serotonin syndrome. Now what? Well, first things first, she's agitated, and we have to do something about the safety threat. She's shouting and trying to attack people. That's not cool. So we should tie her down, right? No. Physical restraints are a terrible idea, because that puts even more strain on the overly excitable muscles. If they get any more active, it can lead to lactic acidosis and an increase in her temperature. Look at that temperature of hers. We really don't want that to get any higher. Severe hyperthermia of greater than 41 degrees can lead to seizures, coma, metabolic acidosis, and ventricular tachycardia. So we should use chemical restraints. One of the common ones used in the ER for agitation is Haldol. Is that a good option in this case? No, because Haldol has some anticholinergic activity, and that would also increase her temperature. Remember how? By decreasing sweating. We should give her the other major medication for agitation. You see this given to the screaming patients in the ER all the time. I'm talking about Ativan, or lorazepam. Now we have to focus on bringing her vitals back to normal. We need to aggressively treat her hyperthermia to prevent those severe complications I mentioned, by cooling her down by using fans and spraying her body with a mist of water. We bring down her blood pressure and heart rate with short-acting agents like nitroprusside and esmolol. If we struggle with stabilizing her vital signs, we can use a medication called cryptoheptadine, which blocks serotonin. So there you have it. In summary, our patient was taking Prozac for her depression and was recently started on Tramadol for her chronic pain. She was one of those people with a CYP2D6 enzyme that does a lousy job metabolizing Tramadol. So she got the serotonin increasing effects of the precursor instead of the pain relieving effects of the metabolite. Since she was also taking Prozac for her depression, the two drugs worked together to boost serotonin activity, and that resulted in Serotonin Syndrome. Thank you very much for watching this episode of Medical Mayhem. If you enjoyed it, please like the video, share it with your friends, and subscribe to the channel. Until next time, this is Medical Mayhem.